Screen. Can you see that screen okay?
Yeah.
Yeah.
Right, I'm also just going to try and see the slides as well. Right, so I'm going to talk this evening about, well, a few things, but amongst other things, I'm going to talk about pilots that were conducted doing liver health checks within the NHS in primary care. And then I'll talk about some of the significance of this and some of the work that's ongoing to try and further the detection of liver disease. I'll try and get the slides to go forward. So just by way of background, I suspect you've seen these slides before or these graphs before, but we've got a major problem with liver disease in the UK. Mortality from liver disease over the last number of decades has increased dramatically. It looked like it was improving in the late 2010 to 2020, but then there's been another big upsurge, another 20% increase in mortality. So big problem that we need to sort. If you look at the map on the right, you'll see areas where mortality from liver disease is very high, particularly the northeast, northwest. So huge differences across the country that we see in mortality. So we've got to sort this out. And particularly disappointingly, 90% of liver disease is potentially preventable. So alcohol-related liver disease, steatotic liver disease, the new name for non-alcoholic fatty liver disease. So that's now called metabolic dysfunction-associated steatotic liver disease. Certainly no easier to say than the previous one. And viral hepatitis. So they're the major causes, and they're all potentially preventable. So we should not have the big problem and the big rise in mortality that we have if we address these issues. So why are we seeing this? Well, there are high levels of harmful drinking in the community, particularly in areas like the Northeast, as you know. We also have rising obesity rates. And there is an interaction between alcohol consumption and obesity such that the risk of liver disease increases tenfold. So that interaction is a big problem, and this is all feeding the rise in liver disease. And this lot is coupled by a complete failure to identify liver disease at an early stage and treat it. And that's because many people are asymptomatic. There's a poor understanding of liver disease in the community and among medical professionals. And there's also a lack of robust pathways to identify liver disease proactively in the community. This slide shows the natural history of steatotic liver disease, just to talk a little bit about what's actually happening in the liver, what we're looking for, and what the consequences are. So if we start at the top, I don't know if you can see the mouse or not here, but steatotic liver disease initially begins with these fat globules, the white globules through in the liver. And as it progresses, that can cause damage to liver cells or hepatocytes, causing inflammation in the liver, so-called steatohepatitis, so fat plus inflammation. And then that can drive the development of scar tissue within the liver or fibrosis. And that can progress on to cirrhosis, where you see all this scar tissue, the red scar tissue within the liver. And that leads to dysfunction of the liver, so liver not functioning and doing its job, and then ultimately leads on to some severe consequences. So a risk of decompensation of cirrhosis, whereby the liver essentially fails. There can be an up to 2% risk of liver cancer per year with cirrhosis, and a 20% mortality at 10 years. So if we can identify steatotic liver disease early and stop people developing cirrhosis, then actually people don't tend to get complications of liver disease. So we must identify early, do something to stop the development of cirrhosis. And the major risk factors for progression are obesity, type 2 diabetes, the metabolic syndrome, which is when people have diabetes, high blood pressure, high cholesterol, etc., and alcohol consumption. And there are lots of other factors involved, things like genetics, etc. We also have an urgent need to improve the diagnosis of liver cancer. In the UK, 5-year survival rates are appalling, less than 10%. And the main reason for this is very few people are actually identified via surveillance. So because liver cancer is asymptomatic at an early stage, people don't know they've got it. So the only way that we can identify liver cancer really is by finding people with cirrhosis and then monitoring them regularly for liver cancer. And if it's identified early, then we can potentially cure it. But unfortunately, rates of potentially curable liver cancer in the UK are about a quarter only. So 1 in 4 people only has potentially curable liver cancer. So as well as identifying liver disease in general early, we have to identify cirrhosis early so that we can get people into surveillance programs to pick up the complications early. So, I mean, I've basically just said this, but how do we reduce liver mortality? We identify people before cirrhosis, intervene, and then we offer surveillance to people with cirrhosis for complications. So people with cirrhosis are often offered ultrasound surveillance for liver cancer every 6 months. And you can see there's an ultrasound with a little small cancer there. And that would be potentially curable if we detect it at that stage rather than the advanced stage. So theoretically, finding steatotic liver disease in the community should be very simple. We know what the risk factors are: obesity, type 2 diabetes, harmful alcohol consumption. We could do a test to find liver disease, so a liver fibrosis biomarker that I'll talk about later. And then we could offer treatment to liver disease. So it should be simple, but it doesn't turn out, well, it could be simple, but it's not done simply. So how could we test for fibrosis or scarring in the liver in the community? So there are some blood tests that we can do. So there's a test called the FIB-4 score, which uses some liver blood tests. So the AST and the ALT, the age, and the platelet count. And if you put that into a calculator, you get a score. If the score is low, that reliably excludes advanced fibrosis and means that person's highly unlikely to have any problem with their liver in the short to medium term. We may need to repeat the test every 3 to 5 years. And obviously, if it increases, then that might suggest they're progressing. The problem with the FIB-4 score is it's easy to calculate, but we get false positives. So in other words, people have a score that is high, but they don't have advanced fibrosis. So we have to do another test to confirm that, such as maybe a FibroScan or this other test called the ELF test, which I'll talk about FibroScan in a moment. So ELF test is another biomarker, but this measures components of the scar tissue itself in the blood. And again, a low score reliably excludes advanced liver fibrosis, but we also get false positives with this test as well. But they can be done anywhere because they're blood tests, so they could easily be done in primary care. So we have the FibroScan, which some of you may have had one. Essentially, this is an ultrasound technique where the probe has a transducer that basically shakes the liver. So you feel a flick in the side of your chest. It shakes the liver and generates a wave going through the liver, which you can see on the right of the screen. And then as the liver disease develops and you get fibrosis, the way the wave flows through the liver changes, or the characteristics of the wave change. And then that can be a surrogate marker for liver fibrosis. And it can also estimate the amount of fat within the liver using this technique. It's a technique that takes maybe 5 minutes to perform. It is painless, straightforward. The disadvantage of it is that people need to attend a healthcare establishment, and there's not enormous numbers of FibroScans around in the community. So often people come to a hospital or a central place to have this done. So the advantage of the blood tests are they can be done at all the GP practices. So that's could be more widely used. And some of this, I'm preparing you for what's coming so that you can understand some of the problems with some of the data that I will show you shortly. So there have been two approaches I'm really going to talk about this to try and improve the diagnosis of steatotic liver disease. There's work that's going out in the real world. So the NHS England primary care liver health checks and the so-called community liver health checks. And they're two slightly different programs that I'll talk about, and they're pilots and they've been successful, and I'll show you some data. And then there's this solid study that's a study that I've been undertaking over the last few years with help from LIVErNORTH being involved. And that I'll talk more about later, which is trying to improve all of this early detection. So let's take the community liver health checks first. So this was developed through NHS England. The money actually came from the NHS cancer program because one of the aspirations of the NHS is to diagnose 75% of cancers at an early stage. And it's recognized that only 20% of liver cancers are diagnosed at an early stage. So they wanted to essentially put money into trying identifying more people with cirrhosis and then enrolling them in the surveillance programs with 6-monthly ultrasound. So that's where the money came from. Of course, us hepatologists were wanting to get more liver disease in general diagnosed to try and intervene at an earlier stage, not just identify people to go into surveillance. So it's been good for us from that perspective as well. So what happened in this program is that there was funding for 22 different networks to have a FibroScan machine that would be mobile, that would go to various places around the community. And there was funding for staff to do the scanning, admin support, etc. And some of the places that these FibroScans were conducted were addiction centres. People who have alcohol problems attend there. So likely to pick up cases, homeless shelters for people who might have viral hepatitis or people who drink lots, community diabetes clinics, because obviously diabetes is a major risk factor for steatotic liver disease, obviously primary care. And we did a number of sessions in large employers like the HMRC and BT and scanned hundreds and hundreds of people. I'll show you some data shortly. So that was the idea. And then depending on the result of the FibroScan, either people got lifestyle advice, if they had a low score that excluded significant liver disease. If they had a moderate score, they got lifestyle advice, and then they'll be brought back for another FibroScan in 2 years to see if things are worsening or improving. And then if they had a high score, they'd be reviewed in the liver clinic to see whether or not they have significant liver disease, and to also try and offer some treatment. So this is the national data that we had up until there was analysis probably 6-9 months ago. And you can see the risk factors that people had who were having these scans. So almost 1 in 20 had viral hepatitis. About a third had harmful alcohol consumption. And the rest tended to be people suspected of steatotic liver disease. So either people with the known steatotic liver disease or people with risk factors like type 2 diabetes. And overall, 98% of these 103,000 people had a FibroScan, and remarkably 7.6% had a high reading suggesting advanced liver fibrosis. So these people would then be offered an appointment in a clinic to have a more detailed assessment. Now, we don't have good data on from exactly what happened to all these patients yet nationally. But if we look at what happened in our region some time ago, after the first year or so, we looked to see what was happening to the people who were being scanned in our region. And we've probably scanned 5,000 people now, maybe more than that in our region. And of those, we had the same detection rate. So 8% had a high score suggestive of advanced liver disease. And of the people who'd then been reviewed in clinic at the time we looked at this, almost 40% were diagnosed with cirrhosis and then went on to have their surveillance for liver complications. 51 patients had advanced fibrosis, so were offered treatment and had ongoing follow-up to monitor. And we did ultimately diagnose 2 liver cancers out of this. So generally a successful program for identifying people with significant liver disease. So then the next phase after that was to introduce liver health checks in primary care. Okay. And I mean, you don't need to know the details of this slide, but essentially this shows a rather complex pathway of how people would have these tests in primary care. And I mean, the first thing to say is it is complicated, and that will be reflected in some of the results, which I'll talk about later on. But essentially, in this pathway, people would have the FIB4 score, which is the simple blood test I talked about in the beginning. And then some people would go on and have the ELF test next if the FIB4 test was increased. And then some people would go on and have a FibroScan. So essentially, people may have 3 separate tests before receiving a diagnosis of cirrhosis or advanced liver disease. And the way this worked in primary care was GPs did searches for codes within the electronic patient record for something to suggest alcohol-related liver disease or high alcohol consumption, people who might have viral hepatitis, a high alcohol intake, risk factors for steatotic liver disease. And because some of those things are very well coded in GP records like diabetes, they were able to identify people to then invite for testing with the FIB4. So there were 12 primary care networks that were funded from across the UK. None of them were actually in the Northeast, largely because we're doing the SOLID study at the time. So that really conflicted with that. But ultimately, in these 12 primary care networks, 47,000 people were identified with risk factors for liver disease and were invited for the FIB4 blood test. And of those, 25%, so 1 in 4 people actually had the blood test to do the FIB4 test. And of those, after people went through the pathway, ultimately 3.2% of those had suspected advanced liver fibrosis. So the FibroScan reading was high. And it was highest amongst people with alcohol-related liver disease, followed by hepatitis C, and then followed by people with known or suspected steatotic liver disease. So fairly high rates of pickup for these. That's an important diagnosis to make. So what were the characteristics of the people who came for the testing? We don't know what the exact characteristics for the people who didn't come for testing because the way data flows, you can't necessarily get information about people who haven't had a test. So that's a limitation of some of this work. But they have done some interviews with people to try and understand why some people didn't come forward, but we can always talk about that at the end. So 59% of people were male. The age or average age was 62. 2/3 of people had a BMI, body mass index, that would just suggest that they were in the obese category. So they'd be at high risk for steatotic liver disease. 42% had type 2 diabetes. The median alcohol intake was 6 units per week, but actually about a quarter of people consumed more than 30 units of alcohol per week. So more than double the UK recommended amounts. Now, I apologize. This next slide or slide series has got a lot of numbers on it, but I'll take you through it. But this is just to give you a feel for how things went through the pathway. And given the complexity, it's quite hard to make this slide look good. So of the 11,000 or so people who had the test, around 70% had a low FIB4 score. So they're reassured. And then they were just suggested that if the risk factors persisted, they could have another blood test in 2 years' time. We then had 7% who had a high FIB4 score. So these people were quite likely to have advanced liver disease. I'll come back to them in a minute. And then we had the intermediate group, where they had an intermediate FIB4 score. So these people as part of the pathway were meant to have an ELF test next. But as you can see, only about half of them, well, slightly less than half of them actually had the ELF test. So although we've started with 25% of people, we've lost a few who are not going to have gone through the full testing pathway. And of the people who did have the ELF, half of them ended up having a high ELF score, and those people then went on to have the FibroScan. Now, if you got to a FibroScan at this stage, actually the people having high FibroScans, 1 in 10 would have a very high FibroScan suggesting probable cirrhosis, and 6% had a FibroScan suggesting probably advanced fibrosis. But still, a lot of these people coming through this pathway still had advanced fibrosis excluded. And then just for the ones with a high FIB4, they skipped the ELF in this because the probability was quite high of these people having cirrhosis. So they just skipped that and went straight to FibroScan. And you can see 1 in 5 people had cirrhosis, with another 8% in this group who had advanced fibrosis. So if we put that all together, 28% of the people who had a high FIB4 score had either advanced fibrosis or cirrhosis, and 16% of people who had the intermediate FIB4 score had advanced fibrosis or cirrhosis. So picking up plenty of cases, but quite a difficult pathway to follow. And I'll come back to that in a minute because there are solutions to making that better. So what were the characteristics of the people who had advanced fibrosis or cirrhosis? So the ones with a high FibroScan reading. So they're this column on the right. So they're significantly older than those that had lower scores. They're more likely to have alcohol-related liver disease. They're more likely to have a higher body mass index, so more overweight, and they're more likely to have type 2 diabetes. So probably no surprises there because they're the major risk factors for steatotic liver disease. So sorry, this again is quite a busy slide, but I'll just take you through it slowly. So I've already alluded to the fact this pathway was rather complex. So probably not surprisingly, the GPs didn't follow the pathway. So about 72% of people followed the pathway correctly. But there was people getting over investigation. So some GPs didn't believe the FIB4 and just decided they would do the other tests anyway. So that happened in 11% of people. And then there was a lot of under investigation, as I've already shown you, people who had a raised FIB4 who then had no further investigations. And there were some people where the pathway wasn't followed, they did the wrong test. But actually that wasn't so bad. But one of the good things in this work was 6 of the PCNs actually had a reflex test for ELF. So what that means is in the lab, if the FIB4 score was high, they would automatically do the ELF test. So it didn't mean the patient had to be called back for another blood test. And probably not surprisingly, those with reflex ELF testing were much more likely to follow the pathway. So helps us think that, well, if we want to be successful here, you have to make life easy and things be automated. So the conclusion on this particular piece of work, well, it's feasible to introduce a liver health check program into primary care, and lots of people can be tested. However, only 1 in 4 people who had the risk factors actually came to have the blood test. So we need to improve the number of people coming forward to get in and have these tests. But we picked up a lot. 3% of people had advanced liver disease or suspected advanced liver disease in this. So it was picking up people, as I've already said, adheres to the pathway. I mean, suboptimal is probably generous, but yeah, it was needs work. But the sites with reflex ELF test were significantly more likely to follow the pathway. So this clearly indicates that pathways should be automated and should take out the need for people to request blood tests, the patients for coming back for lots and lots of repeat appointments, etc. And I've already said that. So next, let's move on to the solid study. So this has been going on for a wee while. Got funding a few years ago. The funding's run out now. The study's completed, but I'll tell you where we're up to. See, I have talked about this previously at one of these meetings, or when we were setting the study up right in the beginning. So the aim of this was to develop an effective pathway to identify people with advanced liver disease and people with risk factors for liver disease. So this is trying to do what we've just been talking about, but I would say in a more scientific way. So we ultimately have recruited 2,500 people from 25 GP practices in Northeast England. So these people are actually attending a long-term condition review or an NHS health check. So when people get called age 40 or 50, which I've just had mine as it happens. I won't tell you it was 40 or 50. I'll let you guess that one. But so people are coming, and the plan with this was if they had a risk factor for liver disease, they'd get a liver health check at that appointment using blood tests. So incorporating this liver assessment into what's going on already. So people with obesity, type 2 diabetes, or potentially harmful alcohol consumption using a questionnaire would, if they took part in the study, had the liver fibrosis blood tests. And as part of this, we've also collected blood tests for better, well, hopefully better biomarkers, novel biomarkers, so new biomarkers to try and improve the way we do this. So I won't go through this in detail, but we had two pathways in this. In one of them, people had all the tests, all the blood tests, and also had a FibroScan. Whereas in the other pathway, only people who had either a high FIB4 score or a high ELF went on to have a FibroScan. And if the FibroScan was raised a little, so we had a much lower threshold in this study, they'd be reviewed by me in the liver clinic so that we could very carefully assess the number of people being picked up. And then the advantage of this work compared to the other is everyone's had lots of other tests to really try and nail down what the stage of the liver disease is. So we did some novel approaches to the delivery of this study, which actually could be replicated in many primary care studies. So the GP initially sent a text message out to potential participants with the information. So there was a link, and if people could then click on the link, they'd be taken to information about the study. If they were interested in taking part, they could then go to an eligibility website where they put in a couple of things about themselves, and then the computer would say, yep, you're potentially eligible. And then one of the research team would ring them and then obtain consent with them over the phone and ask a few questions over the phone. And if people, this was all done electronically, they'd get an email, they'd sign their consent form, the email would ping it straight back through the system. And then they would turn up for their long-term condition review or their health check. And the healthcare assistant, as well as doing the usual things they do, just took some additional blood tests. And also we got a height, weight, and waist circumference. So just a few clinical measurements as well as blood pressure. And then people were advised of the results of the blood tests. And if the blood tests were low, then they got some lifestyle advice and no further action. If the blood tests were raised, then I saw them in clinic. And then we exported their clinical data directly from the GP record into the study database. So that meant we didn't have to do lots of manual input of data. So we had this remote consent, which is a great way of doing it to recruit lots of people in primary care. And then obviously we had the automated data export, which was really good. LIVErNORTH helped put this together, the leaflet that everybody got as part of the study. So looking after your liver, we will need to actually update this one and change it from fatty liver disease to steatotic liver disease. So we will need to do that. And it's a great little leaflet. It was a major regional effort. So you can see all the stars are GP practices that recruited. So this is not just around Newcastle. We're right up to Berwick-upon-Tweed, into Northumberland, down into Sunderland, County Durham. So a big, big effort from many people. And I've certainly got a lot of grey hairs from doing this study because there's a lot of moving parts, but a great team that delivered it. That was us back in Cruddas Park in the west of Newcastle, recruiting our first patient back in 2022, and that was the team there. We're all very enthusiastic and very nervous at that point, thinking, God, are we going to deliver this? And so it's great that we have delivered. At this point, I'll just acknowledge the huge research team that have worked so hard on the study. So where are we up to now? So we completed recruitment at the end of February last year with 2,575 participants. All patients had had their assessments conducted by August, and then the data has all been verified. And Hannah Starr, who's a PhD student working through the Newcastle BHD, the BRC is doing a PhD, and she's just knocked together some really nice abstracts that are being submitted with some initial data. So, the data that's coming through, I think, will be practice changing, because we found a new pathway that is immensely simpler than the one that I showed you before. It will be a very simple two-step pathway that just requires blood tests. But I'll probably present that, or get Hannah to present that, Hannah and I to present that to you in due course. We've got a huge data set. We've got many, we'll be able to answer many research questions. And we've also have ethical approval to follow all these participants for 10 years via their electronic health records. So we will be able to assess the true prognosis of the tests. So as well as knowing what's going on now, we'll be able to look at what happens to the people with low tests. Do they all remain low? What happens to them? And what happens to those with higher tests? So there'll be, I think, a lot more to come from this. So that is all I've got for you. A quick rattle through, and apologies if some of the slides were a bit busy, and I'll stop sharing and then maybe we can have some questions.
Excellent. Thanks very much, Stuart. That was brilliant.